Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to another talk discussion. We are going to finish the rest of 2025 topics. I wanted to start with this talk article. It's not new, actually. It's a good review over Hirsutism. Not in details, by the way. If you want to go through Hirsutism and its management, I really advocate other guidelines. Like, for example, we have the ASHRI guideline for PCO. Amazing, amazing, amazing guideline. And the other differential diagnosis for hyperandrogenism, you can find it in a TOG article called DSD. The DSD is essential for your exam. You can simply Google it, DSD TOG. Differences of sexual development and their clinical implication, because some of them are related also to hyperandrogenism, so you have to go through it. Okay, so this one plus the PCO guideline, the ASHRI guideline, and also the basic knowledge about Hirsutism. You can find it from here. They cover some basic knowledge about Hirsutism. Like, for example, to quantify any case having Hirsutism, you need the Ferriman-Gallwey score. This Ferriman-Gallwey score is really good score to give you an idea if this patient is really having Hirsutism or not. Because some patients are going to tell you that I'm having bothering hair. Okay, where? Where is crucial question. Where do you have this bothering hair? She would tell you all over my body. I'm hairy. I feel I'm hairy. I feel like that I'm having much more hair than my my colleagues or my training partners. Okay, if she is having any kind of sports. So this is normal. This is physiological. This is not abnormal. And it depends on genetic predispositions. It depends on your ethnicity. Okay, this is hypertelorism. This is not Hirsutism. When she is having hair all over her body, and it's not coarse, dark hair, this is hypertelorism. Dr. Ferriman noticed this. He noticed that some women are going to have hairy body more than other women. So he had a cutoff based on ethnicity. This one here is like the best part of the stock article. Any other thing is already mentioned in many other resources. But we always have like a standard cutoff. We used to say that if the score is more than 8 or 8 or more, that means that this patient is having Hirsutism. Okay, well, this is correct, but it's not totally correct. This score can be applied on United States, UK, black or white women. But you cannot apply it for Mediterranean women and the Middle East women, Asian women, South American women, Chinese women, and very specific Chinese women are going to be the Han and Southern Chinese. Those women have different hair distribution in their bodies. So, for example, in Middle Eastern women, they are genetically hairy. So I'm not going to apply the same score for them. I'm going to have a higher cutoff, 9 or more. This would be diagnostic for Hirsutism. For women in the Far East and specific Chinese women, they are going to have very low cutoff. Why? Because they are physiologically, normally hairless. I always tell this to my patient. We are seeking the Korean face texture. We are dying to have the same skin texture of Korean people. They are having flawless skin. Yeah, they are naturally hairless. So those women, when they are having a pheromone Galway score of 3 or more, this is considered Hirsutism. And this is also a strategy question where ethnicity is important in definition of Hirsutism. It's important. And as you can see, guys, we are aiming to have a quantification of specific areas. Those areas are androgenic areas. It's not like everywhere in the body, no. Those are androgenic distribution of hair. The mustache, the beard, the upper chest between the breasts, the inner arm or the upper arms, the upper size and inner size, the back, especially the lower back, the inguinal area. A woman shouldn't be having hair coming upwards to her umbilicus. This is not a feminine distribution. A feminine distribution would be what? Having the inguinal hair like this. When you are having the hair encroaching the umbilicus, this is male distribution. I don't know if you remember it or not from back from the college, but I remember very well a case that appeared in my internal medicine exam. And he was having a liver disorder. He was a male having a liver disorder. And you know, when you are having liver dysfunction or liver failure, you are going to have much estrogen in your system. And the examiner asked me what would be a positive finding for this from the way his abdomen and pelvic area looks like. And he was having a female distribution like this. His abdomen was devoid of hair, totally devoid of any hair. So remember it this way, this is abnormal to happen in a female. To have hair in her abdomen like this is abnormal. To have hair between her breast and upper chest, this is abnormal. Okay, so the difference between hypertelorism and hirsutism is essential in the diagnosis. Okay? Okay. Moreover, we had a very nice cutoff for endocrinology referral. This is also something, yeah, it is mentioned in the ESHRI, but here it's more organized. When should I refer my patient urgently for endocrine assessment? It's a part of the diagnosis, right? Not all patients are PCO. They are having other problems. So when she is premenopausal and the total testosterone is 6 or more, okay. If she is postmenopausal and the total testosterone is 3 or more, this is very important. Okay, count with me, please, because we are going to refer anyone with signs or symptoms of virilization. Virilization is voice deepening, increased muscle bulk, clitoromegaly. If this appear in your scenario in the exam, you need to exclude what? What's your aim right now? You need to exclude what? This is very common exam question. Quickly. Anyone answer, please. Excellent. Androgen secreting tumor. I'm so proud of you. I'm so proud of you that you haven't said ovarian tumors or adrenal. You said androgen secreting. Excellent. Okay, so to differentiate, or I want to look, I want to search for androgen secreting tumor. What do you think? Is it better to ask for a lab testing or for imaging? What would be the best initial investigation now? Imaging or lab testing for testosterone or free testosterone or androgen index? No, actually imaging. Imaging. No, imaging. The lab testing is not going to differentiate for me between ovarian secreting tumor or adrenal secreting tumor. It's not going to do this. You know what? A Sertoli cell tumor can produce very low amount of testosterone, like 5 nanomoles only. So I need imaging. Imaging is going to lead me. Am I dealing with adrenal mass or ovarian mass or none of them? So that I can go through other investigations and take care, guys. To be systematic inside your brain is essential in this exam. They always look for the best next step, right? I'm now at the level of what? I'm now at the level of virilization. Virilization. I'm having signs and symptoms of virilization. And you want to detect if there is a mass or not, if there is a tumor or not. The lab testing is not going to give you this. But if I'm dealing already with a case of hirsutism, yeah, this is hyperandrogenism, but only on the level of hirsutism. What should I do? The very initial thing is total testosterone, free testosterone, or the free androgen index. Any one of them. Which one is the best? Which one is the most sensitive? The free androgen index. Exactly. This is the most sensitive. You got what I want to say? Okay. So be oriented by the scenario. Okay, in the scenario, they told you that the woman already is having an ovarian mass. She's postmenopausal. Her testosterone is 5. Okay? Simply, they are giving me clues that the reason why she is having this high testosterone is ovarian in origin. That's it. So to find the clues in the scenario, again, the free androgen index is the most sensitive, not the total testosterone, not the free testosterone. You can use any of them can be used, but the most sensitive, and if you have to choose one of them in the exam, go for free androgen index, of course. You know why? Because free androgen index is going to calculate total testosterone in relation to sex hormone binding globulin. Most sensitive for diagnosing Hirsutism. Okay? Because sometimes total testosterone can be deceiving. Total testosterone is affected by the amount of sex hormone binding globulin inside your system. Let me give you an example if anyone of part 1 is attending here. We have a clinical situation where the total testosterone is high, but it's not causing hyperandrogenism symptoms or virilization to the woman. Do you know what situation I'm talking about? Excellent. The AIS, okay. It's not what I was asking for, but yeah, AIS is one of the things that Yash is having high total testosterone, but because it's not working, the patient is devoid of the receptors, so the receptors are not working, so the testosterone is not working. Excellent. But let's say the receptors are there, everything is there, she's totally normal patient. She's not having any DSD or anything. She's a normal female. And she's having high total testosterone levels, but still, she's not having any signs of hyperandrogenism. neither her or her baby, a pregnant lady. In pregnancy, guys, the total testosterone is high. But you know why the woman or her baby is not virilized, especially if she is a female? Because on the other hand, she is also having high levels of sex hormone binding globulin. Both of them. So they are, subhanAllah, equals each other. We have equilibrium. So this is why the pregnant lady is not having hyperandrogenism. Neither her baby is going to be virilized by the high total testosterone levels. This is why the free androgen index is more sensitive. This is, by the way, for part one, mainly. This is totally important for part one, guys. You have to understand the relationship between testosterone and the sex hormone binding globulin. And this is why we like the free androgen index. The free androgen index is going to calculate the total testosterone in relation to the binding globulin. We have another situation where the total testosterone could not be very high, okay? But because of the decreased amount of sex hormone binding globulin, the patient is going to have high free androgen index. PCO. Yeah, PCO, excellent. So it's not only about total or free testosterone. It's also about the binding globulin. This is why, yeah, we can go for total testosterone, and yeah, we can go for free testosterone, but which one is the most sensitive? The index. The index is the most sensitive. Okay, الشيء بالشيء يذكر. Or let's also mention what is the importance of DHEA. Let's say, for example, the imaging was not really conclusive for whether I'm dealing with an ovarian cause or adrenal cause. Which one of those can give you an idea about whether it is adrenal or ovarian? Is it the DHEA or androstenedione? Excellent. The DHEA or DHEA is only secreted by the adrenals. So if I'm having high levels of DHEA, by far I'm dealing with an adrenal problem. Excellent, guys. So keep it in your mind also. Okay, in case the scenario is really vague. But usually in the exam, they love asking you about the very initial steps, which is going for the index, or sometimes they give you the testosterone level already and ask you, okay, what would be the best next investigation? Imaging, of course. And if I want to know if this is ovarian or adrenal, imaging, of course. I still don't have a clear diagnosis. I can get help from the DHEA because it has poor sensitivity also. Take care of this. Whether the androstenedione or the DHEA, they are having poor specificity. Take care. And they are affected by the age. Okay, so what basic knowledge is making our life easier. They also talked about idiopathic hirsutism in this TOG article, which is something that you are not going to find in other guidelines clearly, or you may miss it. When can I say that this is idiopathic hirsutism? Exclusion. This is a diagnosis of exclusion. So it means that they need to give me that everything was normal androgens, normal cycle, normal ovarian morphology. See the imaging, okay? And she's having hirsutism. Okay, you may think that this could be congenital adrenal hyperplasia. You may think that, right? Tell me how I'm going to exclude the congenital adrenal hyperplasia. She cannot be having a normal level of serum androgen for as a start, okay? But okay, let's say she is having a borderline serum androgen, a borderline serum androgen. Yeah, if I want to exclude the congenital adrenal hyperplasia, I would ask for or order the 17-hydroxyprogesterone. Excellent. No, first 17-hydroxyprogesterone, and if it's equivocal, I'm going for the synactin test or the ACTH stimulation test. Okay? Okay, Dr. Razan? So first, yeah, the 17-hydroxyprogesterone. Take care, guys, because this is also a strategy question, and I love it, to be honest, because they mentioned a woman who is having hirsutism, and she's having normal levels of serum androgens. They didn't say anything about normal cycles or ovarian morphology or anything. They didn't say anything. They just mentioned that she is having hirsutism, okay, and normal levels of serum androgen. Can you diagnose idiopathic hirsutism in this case? No. No, we can't. So what would be by far the most common cause in her case? Normal serum androgen and hirsutism, PCO. Excellent. PCO. Because PCO is by far the most common cause of hirsutism in women. No, no. I didn't say anything about the 5-alpha reductase or anything. I didn't say anything. That was the scenario in the strategy. If you are talking about the pathophysiology of idiopathic hirsutism, we have a theory. We have a theory, which is, yeah, the woman is having normal menses, normal ovaries, normal androgens, but she is having receptors very sensitive to those androgens. So they are saying that this could be a functional difference in androgen receptors, or she could be having increased numbers of cutaneous 5-alpha reductase activity. So it's something related to her genetics. But it's not a disease. This is something that we can say she's not having a pathological cause. Not a tumor, not an ovarian dysfunction, something related to her skin. Her skin is sensitive to the circulating androgens. Her skin is converting the estrogen to androgens. 5-alpha reductase and vice versa. Okay? You got it? Yeah. This is the theory behind the idiopathic hirsutism. This is what you meant, Dr. Joan, right? By the way, this could be exam question also, mainly for part 1, as a pathophysiology question. I'm going to add it to the Telegram group. Good one. Okay. So again, take care, please, of any other sign and symptom. Take care, please, of any examination findings, like being obese, like being Cushingoid, because Cushing syndrome can cause hirsutism. take care of any skin changes. This also can be signs for Cushing, or what we call in this TOG article, they also mentioned something rare but a good differential diagnosis. Was it up or down? Yeah, it is called, guys, Hair-Ann syndrome. The Hair-Ann syndrome is a subvariant of the PCO. Same to same regarding the pathophysiology, insulin resistance, leading to high LH, leading to high androgens, leading to hirsutism. But we are having a slight addition, which is the presence of acanthosis nigricans. Acanthosis nigricans could be one of the signs for hypercorticosteroids in the system, but take care. When she is not having other finding of Cushing syndrome, this is Hair-Ann syndrome. The Hair-Ann syndrome is hyperandrogenism, insulin resistance, and acanthosis nigricans. And this is also could be exam question. A woman with so and so and so, and during examination, you can see the acanthosis nigricans in her neck. Okay? Take care of this. So far, everything else you already know. They didn't mention anything of very unique about the management or anything. If you want to go through this flowcharts are great, but they are not specific, okay? So in the exam, they go deeper than this flowchart. Regarding the treatment, you all know that it depends on what. Before you are going to offer a treatment for Hirsutism, ask key candidates. Are you there? Please tell me, while you are discussing this case with your patient, what are you going to ask about before offering her any kind of treatments here? No, not severity. Not the impact on her life, no. Thank you. Yes, fertility wishes. First of all, fertility wishes. Oh yeah, are you going to start a family soon? Are you hoping to have kids soon? Because if you wish to have kids soon, I'm not going to offer you COCs. We need time, guys, for COCs to work. We need time. So it's not like I'm going to offer her COCs and whenever she can stop it, she can. It's not going to work like this. This way, I'm not fixing her hirsutism issue. Same to same with HMB. If you are offering Mirena or COC for a case of HMB, you need to bear in mind that they take time to work. They need time, take time to have an effect on the heavy menstrual bleeding. So if you are offering a woman a Mirena so that she's going to remove it in less than 6 months, this is in vain. You are inserting Mirena in vain. Mirena can take up to 6 months to work. So the first thing that we are going to ask about is fertility wishes. Then, okay, she's coming to you and she is already in despair and she wants to have a fix to her problem. So of course it is impacting her quality of life. Okay, so we are going to reassure her that this is treatable and we have excluded the most irritable causes. We have excluded the disasters. We are not dealing with a tumor. We are not dealing with a complex ovarian cyst. So now I can offer you lifestyle modification, of course, because decreasing her weight, any weight loss can improve her signs and symptoms. Any weight loss. We are not aiming for perfection. Okay? If she just lose weight, her axis, okay, the pituitary ovarian axis is going to be refreshed, and we are going to have better regulation of menses and, of course, better effect on the release of androgens. The first line for Hirsutism is COCs. So if she want to get pregnant, I'm not going to offer her the COCs. COCs are going to be offered for 6 to 12 months trial. We can add things to COCs. We can add creams, yeah. We can add laser treatments, of course. Any local management, any local skin management, any cosmetic measure, it can be added. Eflornithine. What is the guideline saying about the topical eflornithine? This topical treatment is contraindicated in pregnancy. In pregnancy. But she can have it if she's not pregnant. Okay? So, yeah, fine. A woman who is willing to get pregnant, you cannot give her anti-androgen medications because they are contraindicated in pregnancy. But if she is contraindicated to take COCs because of VTE risk, for example, or she refused to take COC for whatever reason, I can give her anti-androgen medications plus reliable contraception. So please take care of that through the exam options. If you are going to give her something like what anti-androgen medication, guys? 5-alpha reductase receptor antagonist. We can give her a diuretic, a specific diuretic, finasteride, excellent, that has anti-androgenic properties. Right? So yeah, but those, we need a reliable contraception with them. Any cosmetic method, waxing, laser, the topical fluorescein, it's an addition. They are not ever the first line, except if the woman decline the COC. So theoretically speaking, I'm going to offer first the lifestyle modification and COC. If it is contraindicated, I can think of other options. Okay, got it? Okay, so I had a question regarding, no, why not giving COC for unmarried young ladies? She can have COCs. COCs are not for contraception for her. They are meant to regulate her menses, control the axis, the pituitary ovarian axis. We are like, let's say, a factory reset. You can say so. We are giving her the COC as a factory reset for her system. I'm giving you the COC to put the pituitary ovarian axis on track, in a normal track. A progesterone is not going, you mean a progesterone only? No, don't do this. It's not the first line, not the first line. We can go for a progesterone only, which is having anti-androgenic properties, okay? Or you need the estrogen. You need the estrogen. Those are very unique cases to offer progesterone only. We usually don't do this. Even in the ISHRI, by the way, you are going to find that it's not advocated to do so. You know why? Because something like sapropterin acetate, for example, yeah, it can be used, but guess what? Very high risk for VTE, very high risk. And on the other hand, there is another risk factor regarding the sapropterin acetate, which is going to be the reason why it's now not our favorite at all, even in combined CUCs. They are now advocating the drospirenone over it. I mean, the ESHRI guideline, at least. Yeah, abnormal liver function and up to adenomas. So yeah, they are withdrawing the use of sapropterin acetate for this indication. So no, don't do this. Unmarried, why not taking CUCs? If she want to have cosmetic methods, okay, she can go for cosmetic methods. She can go for laser. Why not if she refused to take the CUCs? But CUCs are not only for hirsutism. CUCs are good for regulating her menses. Right? We are working on the tract, which is going to be good for her if she want to get married and for her fertility wishes. Okay, and we are having hair reduction methods, temporary versus permanent. She can go for whatever she want. This here, guys, part 1 and part 2, both of them can have a question regarding the mechanism of action. We can have the 5-alpha reductase inhibitors like the finasteride. We can have also spironolactone. This is also 5-alpha reductase inhibitor, and also a competitive inhibition over the androgen receptors. And we can have the sapropterin acetate, as I told you here, okay? But the highest risk for VTA. And this is why I'm telling you, try to go for the ESHRI guideline for PCO. It's amazing. And I can reshare this one with you. I don't mind at all. We have a very good infographic regarding it. Okay? Okay. So forget about this. It's not that important. Okay, here we are with the one that you all waited for, the placenta accreta spectrum imaging and diagnosis. In another TOG article, you are going to find the management, and I told you don't depend on the management lines in the TOG article. We have a guideline, but the TOG was great about uterine preservation strategies, how to do a uterine preservation. And I think this is important for part 3, crucial for part 3. If I want to discuss with my patient her wishes to preserve the uterus, I think you guys should go and review the other recording and go through the talk article and even have like a little search about the techniques mentioned in the talk article. Okay. So whether you are a part 1, part 2, or part 3, please give me some attention, because we are going to talk about the pathophysiology of placenta previa and accreta. Please, if you want, you can take a screenshot of this, because this is exam question. And it's a very common recall. The risk of placenta accreta spectrum if a woman is now having a placenta previa and she is having a prior cesarean delivery. In the latest exam, I think they asked about 3 previous cesarean births. So the risk for this woman to have a PES is 61%, increasing to 67 when she's having 4, 5 or more. If she's having only one prior CS, and now she is having a previa, her risk for having accreta spectrum is 3%. Okay, so what happened normally during placentation? If you remember, for part 1, the normal placentation is going to happen during implantation. Okay, so we are having like invasion of the trophoplasts inside the endometrium. But guess what? It's not haphazard process. No, this process is very regularized and very delicate. And they are having like a borderline for this invasion. They are not going to invade indefinitely, no. The trophoplasts are allowed to invade the endometrium only, not the myometrium. Some of those trophoplasts, well, they are called extravellus trophoplasts. They are small and they can invade the spiral artery of the uterus, and they can appear in the maternal circulation. Can you have like an idea how can we get usage of those extravellus trophoplasts? Can we use them for something? Do they have a clinical benefit for us? NIPT, cell-free fetal DNA. Yes, this is the source of cell-free fetal DNA, guys. Extravellus trophoplast, part 1 exam question. And when it appeared, everyone was opening his mouth like, what? What is this? So if it's not there, you can say trophoplast only, yeah. So this is the embryological part, or the embryo cell, that is going to invade the spiral arteries and appear in the maternal circulation. Those extravellus trophoplast. Okay, amazing. So now I know what I'm looking for in cell-free fetal DNA. This is how we get the fetal DNA from this. Okay, so let's say the invasion went deeper than the allowed borders. What are we going to have? PES. This is what we are going to have. This is also very important for part 1. The timing for extravellus trophoplast invasion. And for us as a clinicians, we are working in obstetrics now. If this is important for you guys to know that the second wave is going to be completed by far 22 weeks, in some literatures around 18. So this is why they are having this interval, 18 to 20 weeks. This is important for us. Yes, it is. Because this is the timing that if you are going to give aspirin, we're going to start it from here. Or a little bit behind the 18 weeks. Why? Because if I want something to help me with a good trophoblastic invasion, I need to give it by the time of the second wave invasion. This is why if you offer aspirin, for example, later than this, its effect is going to be very weak. What already happened had happened. The invasion happened and that's it. You cannot modify it or modulate it. This is why if a woman is having an adverse outcome in her previous pregnancy related to the placenta, many guidelines are advocating giving her aspirin even before getting pregnant. In our college, okay, in the RCOG, we prefer starting the aspirin once she know she's pregnant. But something like the Irish college, they are advocating starting the aspirin when she is trying to conceive. Why? Because we have already known that she had a small baby because of a placental reason, or IFD because of a placental problem, or she is having antiphospholipid syndrome. So yeah, I'm going to start the aspirin very soon. Why they are doing this? They are doing this to modify the way the trophoplasts are going to invade the placenta. Got it? Another thing which is really important, when we are aware of this, we are going to be aware of whether methotrexate is going to be beneficial in cases of placenta accreta spectrum or not. How? Many doctors believe that if you are going to deliver a baby and then you found out that this is attached placenta, it's very deep. Okay, I'm going to leave it in situ right now because I cannot do hysterectomy, for example. Shall I give her methotrexate? No. Our guideline is saying no use for methotrexate. You know why? Because once the syncytial trophoplasts are mature, you cannot give methotrexate to stop them or detach them or cause their dissolution or whatever, or lysis. There is no benefit. So this is why so far when we are dealing with PES, we are dealing with it as a whole. The whole placental mass, either to remove a part of myometrium together with this attached placenta, or to remove the whole uterus, or to leave it in situ and plan for hysterectomy later on. Those are our options right now. Got it? Okay. So the talk is really informative about the pathophysiology. Great about the pathophysiology, to be honest. And they also talked about the spiral artery remodeling when we are having invasion up to the myometrium. Do you think if I'm having invasion up to the myometrium, the spiral artery is going to be looking the same? No, it's not going to look the same. It's going to dilate. So keep it in mind, because this is important for me when I'm going to put my ultrasound probe and turn on the Doppler. I'm going to see this. I'm going to see the abnormal blood flow, the turbulence. I'm going to see the lacunas. This is why we are having abnormal lacunas with PES. So normally, as I told you before, we are having borders, country border, let's say. This is like the country legal border for the trophoplast invasion. They are fibronoid layers. They are not one or two, they are three. But the richest one, the deeper one, the one that is going to be the layer where the detachment of placenta happens during labor, is the Nitapach layer. She's a German scientist. So this Nitapach layer is where the placental detachment happened during labor. Very common exam question for part 1. if we are having invasion for this, I'm dealing with no normal detachment of the placenta. I'm going to have adherent placenta during the third stage. So now I have talked to you quickly about the pathophysiology. Now let's see what's going to appear in the ultrasound. First of all, this classification could be exam question, and I told my candidates about it, and I'm going to tell you also, please go through the grades, because so far, and I have seen candidates do it incorrectly up to this moment. So tell me, guys, let's examine you. If you are having a placenta invading up to the serosa, are you going to call this previa, accreta, increta, percreta? It is invading up to the serosa. I wish I had a bet. If only I did a bet with you over this question, I would gain a lot of money. No, it's not percreta. No. Up to the serosa is increta. Invading the serosa, percreta. I told you, I have seen many candidates do it incorrectly. See, guys, this is the myometrium. This is the endometrium. Okay, and let's make the myometrium with the yellow color. It's not why I cannot see it. Okay, this is the myometrium, and this is the serosa. So if I'm having a placenta up to the serosa, it's not invading the serosa, this is increta. If I have invaded the surface of the uterus, the serosal surface, this is percreta. Is it going to be easy to differentiate between them macroscopically by the naked eye? By the naked eye, it's not going to be that easy. No, it's not going to be that easy because the serosa is a very delicate layer. So actually, if you are seeing prominent vessels here at the surface of the serosa, okay, beneath it, I mean, you cannot really say if this is increta or percreta. But there is another naked eye sign to differentiate between them. And if I'm an examiner, I would bring this as an exam question. I would say in the scenario that you can see a good demarcation between the uterus and the bladder. You can have a clear surgical plan between the uterus and the bladder. Now, tell me, please, is it increta or percreta? Yeah, now it's increta. Both of them are going to have the purple or bluish distension or the vascularity over the surface of the uterus, both of them. But in increta, I'm still having invasion only in the uterus. I'm not over the uterus or beyond the uterus. I'm limited to the uterus. In percreta, you are going to be not able to see any clear surgical plan between the bladder and the uterus. Normally. Except a subcategory of percreta, which is very, very hard to differentiate between it and the increta. 3A. 3A is when the placenta encroach in the serosa. So now you can see the vessels in the serosa, but there is no invasion to any other organ. This is something, guys, by the naked eye, you cannot differentiate between it and the accreta. Okay? Got it? Both of them have hypervascularity? Yes, definitely. Yes, definitely. Both of them I can see bulging? Yeah, I can see some bulging. But really, if I want to differentiate between this grade and accreta, it's almost impossible by the naked eye. If we are having bladder invasion or pelvic tissue invasion, yeah, now it's going to be easier for me. So in the exam, really, if they told me that I'm having hypervascularity, I can see the dimple sign, okay, which is the traction of the cord without separation, of course. It's attached. And I can see a clear surgical plan between the bladder and uterus, I would go for accreta. I'm not going for percreta. You need to give me another sign to say that this is percreta. If they mentioned you can see the placental tissue, not only vascularization, no, placental tissue up to the serosa or invading the surface of the uterus, yeah, okay, now percreta. Even if there is a surgical plan available between the bladder and uterus, yes, yes, because I can see the placental tissue invading the surface of the uterus. Here, I can see only hypervascularity without the placental tissue itself invading the surface of the uterus. In real life, it's not that easy, but I'm talking theoretically speaking. So you got the difference between them, at least theoretically, in the exam scenario. Take care of them, please. This is what I'm telling you. Theoretically, you are going to see the placenta itself, not only vessels, the placental tissue itself bulging to your face. It is now the thing that is in front of you. You cannot see any serosal surface. You cannot see anything related to the uterus. The placenta is in front of you. This is 3A. But if you can see hypervascularity only without seeing the placental tissue in front of your face, this is accreta. Okay? And please remember, both of them are having clear surgical plan between the bladder and uterus. It's going to be a tricky question, but not for you. Not for you. Okay, now let's see the ultrasound. And before the ultrasound, have a look over those pictures here. Here I can see the vessels. And to be honest, I cannot tell. I'm going to be honest with you guys. I can see prominent vessels and I can see a hint of the placental tissue, but still I can see it's covered with a membrane. This is not like a frank placenta in front of my eyes. Frankly speaking, can you see this as a frank placenta in front of you, or you can see just hypervascularization with bulging, of course. We can see the bluish or purple bulging. Yeah, this is accreta. Excellent, this is accreta. And yeah, you can see the prominent vessels, but they are still covered with the serosa. This shiny membrane, this is the serosa. Here, what is this? No, it's not prominent vessels. No, it's not. This is adhesion, dehiscence, guys. Dehiscence is by far more common than abruption. So if a woman is having intrapartum hemorrhage, severe hemorrhage, or antepartum hemorrhage, and you are thinking of abruption, think first of dehiscence. Dehiscence is more common, especially if she's having a previous cesarean section, of course. I can see here a bulge, but it's like a blood collecting bulge. Yeah, there are some vascularities, but it's not like this one. Definitely not like this one. And I can see here that this bulge is demarcated by the myometrium. Okay? So yeah, by the way, they can come in the exam, of course. So let's see, during the ultrasound, what should we do? Ultrasound imaging, by the way, is not that easy if you are haphazard, if you are everywhere, if you are not knowing what you're looking for. Do you remember what is pre-test probability and post-test probability and so on? Statistics, the nightmare. I love statistics. I love it. A pre-test probability is before doing the ultrasound. Simply, let's take it simply. Before doing the ultrasound, and depending only on the background risk of this patient, having previous cesarean sections or myomectomy or any uterine scar, multiparous and so on. I'm having odds ratio, okay? So that this woman is having PES, right? With only the risk factors, right? Okay, so this is pre-test probability. And here I'm going to have the TVS. Now I'm going to have another odds ratio here, which is called post-test probability. If the TVS is accurate, we are going to have higher odds ratio here. If the TVS is not accurate, I'm going to have almost the same odds ratio. And this is why we are saying any ratio, when it's equal 1, it means what? It means that the thing that I'm testing is insignificant, has no value, has no benefit. It's not even harmful. No benefit or no harm. It means nothing. So it works like this. Before doing the TVS, we are going to calculate the odds ratio. And, okay, after doing the TVS, we are going also to calculate the odds ratio of PES in those women. If the odds ratio here is higher than here, it means what? It means that the TVS is sensitive, is good. It's a good test to detect the PES. This is what pre-test probability means. It's not that hard. Wallah, it's not that hard. Come on. Come on, love the statistics with me, guys. Love it. I love it, so you have to love it with me. So, for example, we are going to take the signs and symptoms, clear history, everything, okay? And then I'm going to do the ultrasound. Okay, so the ultrasound is going to give me some features. Those features, okay, I'm going to record them. And after labor, I'm going to see if this woman really had a PES or not. If this woman really had PES, it means that the ultrasound is good, is sensitive. right? Because it detected that this woman is having PES. You got how we are going to calculate the odds ratio? With or without the ultrasound, how many women are really detected to have PES? And compare. And compare. Okay, anyway, women who already had a high pretest probability or a high suspicion of PES from ultrasounds should therefore be assessed in a designated PES center. Forget about it. We are going to refer them to the PES clinic or center. What are the ultrasound features? Come on, really? It's still hard? Like, really? If I do the ultrasound for some lady and I detected the signs for PES, and I really detected during labor that she is PES, that means that the TVS was good, right? That's what pre-probability testing and post-probability testing means. خلاص, anyway. Let's see the ultrasound features. The first one would be the loss of the clear zone. I love it too, but they don't. What is clear zone? This clear zone, guys, is simply the myometrium. So if you don't have this clear zone, it means that I don't have a myometrium. This is the myometrium. And I can delineate the placenta for you. I can see it here. Exactly. I'm going to count 1, 2, 3. Okay? And you are going to see it now clearly. 1, 2, 3. So if I don't have this hypoechoic plan, that means the placenta is have invaded the myometrium. The myometrium thickness is very prognostic of probability of this woman to have dehiscence and of course PES. So if the myometrial thickness here is less than what, this woman is very liable to have dehiscence or uterine rupture, especially if we tried VBAC. This was mentioned in the guideline of VBAC. Again, we have a thickness. This thickness here is going to give us likelihood ratio of uterine rupture during VBAC. If it's less than how many millimeters? 2 or 3? Less than 2 or less than 3? If it's 2 or less in the guideline, I know that 3 was mentioned in another TOG article. So we need at least more than 2 to offer this woman a VBAC. If she want to have, not of course a PES lady, no, I'm talking in general. I'm talking about the myometrial thickness. You cannot offer a woman a VBAC if she's having a myometrial thickness 2 or less. If this woman is having myometrial thickness 8 millimeter, her risk ratio to have uterine rupture during VBAC is very, very low. By the way, I think this appeared as a recall before. Okay, so here, regarding PES, I also need this plan to know that this placenta is not invading the myometrium. If the cleared zone have been lost, that means usually that I had a myometrial invasion. Okay, by the way, sometime if you're really, really good in the ultrasound, you can see the Nitapach layer. It's going to appear as, but at term, not before term. You are going to see this hyperechoic layer. This hyperechoic layer, this white layer, is the Nitapach layer. Okay. So the loss of clear zone is our first ultrasound feature for today. But take care. What? It's really good marker and everything, of course. But it varies with advancing gestation. And it varies with bladder filling. Because sometime with a fully bladder, distended bladder, you are going to see like a distension also in here, and it may appear thinner than normal. So you would be having like false positive alarm that this is a myometrial thinning. So yeah, the loss of clear zone is a good one, okay? But it is also very sensitive to probe pressure. So please take care of that. Don't press so deep. And if the bladder is full, it can affect the myometrial thinning appearance. And also, if the placenta is posterior, like mine, most of the times, which make me very less liable to have a placenta previa. I always have a posterior placenta. It's very difficult for the ultrasonographer to have like a good evaluation for the placenta when it's posterior. Yeah, it's good, but it's not good for the ultrasonographer because the baby is always in front of you. He's hiding the placenta. Yes, dear. So that was the first ultrasound feature. Okay, so yeah, okay, so Dr. Momena is saying that the question regarding the myometrial thickness appeared in January 2025. Yeah, I know. I know it was a recall, but I don't remember the year, of course. In the guideline, again, you can find it in the guideline of VPAC. You can find it in the guideline of VPAC. You need a minimum amount of myometrium to be there to offer the VPAC. If it's not there, you cannot offer the VPAC. This woman is going to have dehiscence or rupture. So in the guideline, they mentioned when it is 2 or less, it's not favorable to offer her a VPAC. In the TOG article, another TOG article, I think it was the uterine niche, if I'm correct, they mentioned the cut of 3 millimeter. It's the same. So I need something bigger than 2. I need something bigger than 2 so that I can offer the VBAC. From 2 to 8, okay? From 2 to 8, you can offer the VBAC, of course. If the myometrium is more than 8, that's amazing. That's amazing. Of course, I can offer it. But from 2 to 8, there is a risk for dehiscence and rupture. Got it? Okay. The upcoming sign, my favorite. the abnormal placental lacunae. And the abnormal placental lacunae can be very deceiving. Why? Because sometimes you can see the lacunae normally in a very normal low-risk pregnancy. But take care that lacunae are different from lakes, or what we call placental lakes. When they are abnormal, we give it the term lacunae. When they are normal, we prefer to call them placental lakes. I always call it lacunae, but normal and abnormal. Anyway, whatever you are going to call it. A normal lacunae, guys, is going to be regular, hypoechoic, of course, and most importantly, have different sizes, and mostly they are small. And if you apply the Doppler, you are going to find normal flow Doppler. But in PES, you are going to find a festival or a carnival of colors. Number one, they are irregular, as you can see, different shapes, different sizes. And if we apply the color Doppler, we are going to see festivals of colors. Turbulent flow. Both of them are hypoechoic spaces. Both of them can be numerous. But when they are large, irregular, with turbulent flow, those are abnormal placental lacunae. Okay? So the distortion of the cotyledons, this is the pathophysiology, is because of what? Because of abnormal placentation, right? Okay. Do you think that this is a reliable sign, like 100% sensitive for PES? It's not 100% sensitive. No, it's not. In the exam, they may give you a picture, they may give you the description of the ultrasound appearance. They are going to tell you that the placenta looks like a Swiss cheese or a moth-eaten cloth or whatever. The thing that is going to tell us that this is a reliable sign for PES is Doppler mainly, guys. And again, it's not 100 sensitive for PES because this could be placental tumor. Everything is possible. Okay, the upcoming one is bladder wall interruption. The next sign would be the bladder wall interruption. Okay, so regarding bladder wall interruption, also take care. I should see the smooth line of the bladder wall here, like this. And this is our bladder with the urine inside. If I can see interruption in the bladder wall, sorry. This could be many things. Many things, guys. It could be an artifact. It could be chronic inflammation. It could be a fistula. It could be a tumor. It could be anything. But to say that this is PAS, we should see new vascularity at the serosal surface. not only the interruption in the bladder wall. Interruption is good and everything, and they have a name for it. It appears like a railway's um, sorry, a railway bridge or the equal sign. Okay, it's going to look like this. But again, is it like 100% sensitive sign? No, without the bridging vessels, it's not 100% sensitive sign. So, exam question. What would be the most sensitive ultrasound feature to diagnose PES? Bridging vessels, like this. This would be the bridging vessels. This is the most important signs, guys. The abnormal vascularity between the uterus and the bladder. So the equal sign or interruption sign or the railway, it's called what? Yeah, the train railway. Yeah, the train railway. All of them are okay, okay. But without the new vascularity, I cannot say that this is PES. Okay, here they talked about thinning, not total absence of the clear zone. Can it be a sign of PES? Yes, it can. Sure. If you are having thinning of myometrium less than 1 millimeter or totally undetectable, this is what? This is invasion of the myometrium. So this is just like the sign of absence of the clear zone. It does not mean that I can diagnose the PES only because I'm having myometrial thickness like this. This could be what? This part where the myometrium is thinned this way. This could be a niche, but it's not an invading placenta. So again, what would be the most remarkable sign for me? Bridging vessels. Excellent. Because naturally, you are going to have thinning of the myometrium. This is natural. And as I told you, sometime myometrial thinning could be because of your pressure over the probe, the over distension of the bladder. Okay, another ultrasound sign is placental bulge. Placental bulge could be normal or abnormal, by the way. I'm not going to say normal. Of course it is because of another pathology, but it's not PAS. But yeah, it is one of the ultrasound features. If you are now working with statistics, you can make a study defining the sensitivity of each and every ultrasound feature in detection of placenta accreta spectrum. So you are going to have an observational study over women who are having placenta accreta. Okay. Usually it's going to be cohort because we need a lot of women, and you are going to observe them. Okay. And then you are going to detect how many of them are really having placenta accreta at birth and how deep the placenta is. It's going to be a good study. Who is willing to do this? A very good one. I really have many ideas for good studies. Anyway, placental bulge, it's a good sign. It's not a bad sign. But again, this placenta herniation could be because of what? of a weak uterine wall or dehiscence or because of the myometrial thinning. So this is why, again, it's not 100% sensitive sign unless we have what, guys? Unless you apply the Doppler and see what? The bridging vessels, yes, the new vascularization in the bladder wall. Excellent. Okay, so here you can have, you can see the lacunae, you can see the placental bulge. So any woman with a placental bulge, I'm going to tell her you are having a PES. No, no, take a breath, be calm, get the other features, then make your diagnosis. Okay, so okay, the other ultrasound feature, it would be what's called focal exophytic mass. All of those can be in the exam as a choices, and they would ask you which one of them is the most sensitive for PES. We know the answer so far, but can you see this? Hmm. Can you see this? So this is normal, this is abnormal. Can I say for sure that this is because the placental tissue has invaded the serosa? It could be a placental tumor, not a PAS. Yeah. So this is why, again, the only thing, guys, the only thing that is really diagnostic for PES, yeah, the features are great, they are helpful, but the bridging vessels are our aim. You cannot diagnose a PES without Doppler. The other sign is separation sign. Yeah, this is the bridging vessels. When you see vessels between the uterus and the bladder, those are the bridging vessels. Those are the uterovesical hypervascularity. With loss of the clear zone, with no appearance of the myometrium, with placental or without placental bulging, with the separation sign or without it. What is the separation sign? This is something that you can play with your probe. You are going to press gently with your probe, okay? And then do a rapid release. When you, like the rebound tenderness, something like the rebound tenderness, but with the probe. So we are going to have a gentle pressure with the probe and then rapid release. What should we see? You are going to see with the gentle pressure a uteroplacental interface. This. Okay? And then when you are applying the pressure, you are not going to see this space. And then when you remove suddenly, you are going to see the interface again between the placenta and the myometrium. Anyway, this is also not a very reliable sign. And it needs someone who wants to play with the ultrasound, to be honest, like me. And his eyes are very sensitive to the echogenicity of different layers. So if you wish to try it, you can. If you don't, it's up to you. You are just looking for different echogenicities with and without this pressure. Okay? Again, it is a rule out sign. So it's not like if it's there, there is a PES, or if it's not there, there is not a PES. No. It is having negative predictive value. This is why it's rule out sign. If you see the separation sign, this is normal. I can see the normal interface between the placenta, the myometrium, the serosa, and the abdominal layers. Right? So if it's positive, this is unlikely to be PS. But is it diagnostic? No. No, it's not. The Dopplers. Yeah, now we're talking. So guys, when we see uterovesical hypervascularity or subplacental hypervascularity or bridging vessels, those are the signs for PES. Because you cannot lie yourself or lie the appearance of the joining blood vessels between the two organs. And not only we are having like vascularity in here, no, it is hypervascularity. It's a festival. This is a festival. It means that we are having numerous, closely packed, tortuous vessels. This is what? This is the remodeling of the spiral arteries. Do you remember when we talked about the spiral arteries? The spiral arteries are wider in diameter, more tortuous, and numerous. Yeah, because of the abnormal invasions. Okay? So can I see this hypervascularization? Yes, of course, if it is PES. Can I see it by the 2D? Okay, we can see it by the color Doppler. Or you can see it, of course, by the power Doppler, whatever you want. You can even see it 3D like this one. Okay, so if you apply also the color Doppler, you can see the bridging vessels. See how it looks like? Very prominent. Okay, this is the sign that you should make sure that it is there. Bridging vessels. Bridging vessels. If we want to talk specifically, okay, in terms, just having hypervascularity like this, okay, is not enough to diagnose the PES. Because hypervascularity could be normal, as I told you. But what is sure sign of PES? Let's say theoretically speaking, in correct terms, in correct ultrasound terms, if you have to choose between hypervascularity and bridging vessels, which one is more sensitive to diagnose the PES? Bridging vessels, excellent. Why? Because again, the hypervascularity could be a normal finding. Okay, so here we are finally with the bridging vessels, which is by far the most sensitive for us. No way anything else could lead to vessels running perpendicular to the myometrium invading the bladder. There is no other diagnosis. Okay? Except if we are having like a choriocarcinoma also. But I don't care. I'm having a placenta invading the bladder now. So yeah, this is now the accreta spectrum. I'm having a sure sign of the accreta spectrum. So it is more predictive than hypervascularity, okay? And the lack of new vascularity on the serosal surface is an important feature differentiating between PES and dehiscence, right? In dehiscence, we can see the lacunas. We can see the lacunas. It's fine. We can see the myometrial thickness. You can see normally intracervical lakes, by the way. It's because of the dilatation of cervical vessels. Okay, it's not like it is a sign of PES all the time. No, not all the time. Yeah, it can be a very bad sign because we are having the placenta invading the cervix. But alone, it's not that diagnostic. So I wanna show you the difference between the dehiscence and the PES. Yes, here we are. Here. Because this is exam question. Let's take it one by one. Both of them are having myometrial thinning. Both of them are having loss of clear zone. Both of them can be having absence separation sign. Because it depends on what? It depends on the thin myometrium, after all. Both of them can be having the placental bulge. Not that common in dehiscence that you would be having the abnormal lacunas. But can you have lacunas? Yeah, we can have lacunas already. But it should be regular, not irregular. But see, Doppler. The Doppler flow inside the lacunas are going to be high in the PES, and it's going to be low or no flow in the dehiscence. The dehiscence is a normal placenta. The defect is in the myometrium, not in the placenta. So I'm not going to have a bladder wall interruption or bridging vessels. And it's not that common to see the exophatic mass. Already, it's very rare. This is exam question also, guys. So keep in mind, dehiscence, I'm dealing with a thin myometrium, but I'm having a normal placenta. So I'm not going to see the abnormal lakes. I'm not going to see bridging vessels, not going to see um, bladder wall interruptions. In all cases, the bladder wall should be smooth. Okay, it's not invaded, so it's not going to be interrupted. Which chart? With which chart? Okay, you can find other things about the advantage and disadvantage of the MRI, the rule of MRI, according to the author point of view. Is 3D is good for us? Yes, of course, it's going to give you better image of the invasion and the irregularities in the bladder wall and so on. But I don't think you need a 3D to make a diagnosis for PS. Doppler is a must, not the 3D. Okay? Again, for the cervical lakes, because this is a strategy questions. And the cervical lake was one of the options. If you are having um, intracervical lakes, but the Doppler is normal. It's not vascularized with great volume and speed. Okay? Is that mean that this is a placental invasion of the cervix? No. This is the cervical vascularity. But when the intracervical lakes are going to be one of the features of PES, when a part of the placenta is the reason why we are having this intracervical lakes. So these lakes are continuous with the placenta. Got it? Not separable from the placenta. Again, if you are having those lakes in the cervix and they are continuous with the placental tissue, then yes, this is PES. But if they are separable, we are just having intracervical lakes and has nothing to do with the placenta, this is cervical hypervascularity. And by the way, you may discover later that they are cervical tortuous veins or varicosities in the cervix. So I need them to be continuous with the placenta to say that this is PES. Yeah, if it is continuous with the placenta, so yes. Now this is type 4. Yeah. Okay, so here we are. We have covered every important feature, ultrasound feature. Okay, and this was the placenta accreta spectrum imaging and diagnosis, issue January 2025. If you have any question regarding it, I'm all yours. The other one is in October 2025. It's about the management update. And it's talking about maneuvers or management line that you can take if the woman want to preserve her uterus. And this is what I want the OSCE guys to go through, because this could be a station, guys. This could be a station. So we have already the recording for it. You can find it in the YouTube, I think. Okay, so I don't think you have any questions.